So my mini lecture today is going to be acute MI in adults 65 or older that leads to cardiogenic shock requiring hemodynamic monitoring. So pathophysiology is the acute myocardial infarction, or MI, is a sudden blockage of blood flow to the heart, and this can lead to cardiogenic shock. Cardiogenic shock occurs when the heart does not pump enough blood and oxygen to the brain and other vital organs. This is caused by damage to the left ventricle of the heart, which is the main pumping chamber of the heart. So this occurs when there is a significant decrease in the function or pumping ability of the heart, usually in one of the lower chambers. When the heart cannot pump enough blood in and it can't pump enough blood out, perfusion to the body is diminished, and this can cause the vital organs of the body to shut down. Some risk factors that I'm going to talk about, I'm actually going to try and gear this presentation more towards cardiogenic shock versus a myocardial infarction. But risk factors are history of MI, coronary artery disease or heart valve diseases, weight, diet, smoking, hyperlipidemia, diabetes, hypertension. Asians and Pacific Islanders are at the greatest risk for developing cardiogenic shock after an MI, and women are also more common than men to develop cardiogenic shock. And that's just due to the fact that women usually don't seek prompt treatment when MI symptoms manifest. And also, obviously, greater than 65 years of age, anyone over that age is at a greater risk just due to their age and their comorbidities. So prevention for an MI and also for cardiogenic shock is prompt detection and intervention during the MI. You also want to try to control your hypertension, your hyperlipidemia, and diabetes. Stop smoking, and of course, diet and exercise, and a heart-healthy diet too. Some clinical manifestations, signs and symptoms of cardiogenic shock, hypotension, shortness of breath that comes on pretty suddenly, sudden tachycardia, loss of consciousness, weak pulse. The patient will be very diaphoretic, and one of the big telltale signs is oliguria. For a nursing assessment, nurses should really monitor the vital signs and pay particular attention to blood pressure and pulse rate. You want to assess the cardiac function, heart sounds, assess for issues with the cardiac function, look for edema or jugular vein distension, because that will let you know if the patient is overloaded with fluid, because you're going to be giving the patient a lot of fluids as they recover. Also respiratory, listen to lung sounds, monitor breathing status. Like I said, since the patients are receiving large volumes of fluid, they could have potential of accumulating fluid in their lungs, particularly if they are vented. They'll be sedated and therefore won't be able to ambulate and are just at higher risk for developing pneumonias. Also neurological status, so orientation, their neurological function, and just their level of consciousness too. And another super important thing, again, I'm just going to keep repeating this, is monitoring their eyes and nose. So some labs and diagnostic tests, I've broken this down into two categories. One's for the actual myocardial infarction and the other for cardiogenic shock. Some labs that you would want to do for an MI would be like troponin levels, the creatinine, myoglobin, just serum cardiac markers, ABGs, very, very important, and lactate levels. And for cardiogenic shock, it's really going to be blood pressure measurements, sometimes x-rays. Obviously, we're going to do EKGs and want to keep them on a continuous cardiac monitor. A Swan-Ganz catheter, which I'll be talking about in a minute, is one that's used for the hemodynamic monitoring a lot, in a CVP monitor too. Hemodynamic monitoring is very, very critical for the first 24 hours for patients who have had an acute MI and are in cardiogenic shock. So their hemodynamic monitoring is needed to be able to detect early signs of poor perfusion. It's difficult to do this just with a regular blood pressure cuff and just on a regular cardiac monitor, which we want a more invasive monitoring, more hemodynamic monitoring with like a Swan-Ganz catheter. And this is used to assess the state of the ventricular performance of the heart. And here's just a couple pictures of Swan-Ganz catheter. Like I said, hemodynamic monitoring is essential for early detection of poor perfusion, and the picture on the left just shows you the catheter, how it's floated up through into the pulmonary artery, and just the ranges of monitors they can do. It can give you information about the right atrium, the right ventricle, pulmonary wedge pressures, and then the pulmonary artery. So it really gives you an actual picture of the heart, if you would like to call it that, with monitoring different areas of the heart that you can't do just on a regular cardiac monitor. And this PAC catheter is actually what is inserted into the heart. And it's inserted through the internal jugular vein in the neck, and it goes through the right side of the heart and into the pulmonary artery, and it's very good at monitoring. Some pharmacology for these patients. Again, I broke it into two categories. So for you treat the MI and then the cardiogenic shock. So thrombolytic therapy, beta blockers, aspirin, ACE inhibitors, statins, and you're really going to focus on a lot of vasopressors and fluid resuscitation with these patients as well. So, you know, they might be on dopamine, epi, norepi, and then neo as well. And just some non-pharmacologic care of these patients would be cardiac rehab after their recovery period. We should also make sure that they are on a sodium and fluid restricted diet while they're in the hospital, and try to maintain that after they go home. Again, weight loss is very important. Smoking cessation is critical. And then I also put in there counseling. So like with a dietitian they should meet, perhaps with a social worker or some type of care management to help them outside of the hospital, try to get appointments made, or have people come and help because they might need home health care, whatever can be done, and also spiritual support. A lot of people will need that sometimes as well. The nursing interventions for the cardiogenic shock would be to monitor intake and output. So oliguria is an early indicator of the heart failing to perfuse. So once you get that Foley catheter in, you should be monitoring their eyes and nose hourly with these patients. We have the whole MONA, morphine, oxygen, nitrates, and aspirin. That's probably more on the MI side of things when they initially arrive at the hospital. Management of cardiac output, so you're really going to want to monitor for decreased cardiac function. That's where those CVP, Swan catheters, hemodynamic monitors come into place, so that they can really indicate if there is a decline in the function of the heart for this patient. You're also going to want to monitor their labs, particularly ABGs, because they will tell you a lot about what is going on. Their electrolytes, their lactate, and glucose is very important too, because sometimes the patients are diabetic and that will inhibit the healing process for them. And other times coming out of surgeries, there is a lot of D5 that some of these medications will flow through, which can also elevate their glucose levels. And you are going to be doing a lot of drip titrations for these patients, like I said, with the norepi, DO, and whatnot. Some complications of hemodynamic monitoring. Infection, that's always a major concern. When the catheter is placed through the jugular vein into the heart, you can get cardiac wall perforation, pulmonary artery rupture, blood clots. They tend to accumulate at the tip of the catheter a lot of times. And then a pneumothorax is also, unfortunately, a complication that can happen when they're putting these lines in patients. Patient education. So the goal is to educate the patient on prevention of another MI, because the whole reason that they went into cardiogenic shock is because of an MI. You want to discuss how to control their hypertension, their hyperlipidemia and diabetes. Again, stop smoking, diet and exercise, a heart-healthy diet, continue taking all your medications that you are discharged home with. A lot of times they do not want to continue taking their medications, and that's bad. Educate them that they need to keep all their appointments, their follow-up appointments with their primary care and cardiologist, and they will most likely need to attend a cardiac rehab program as well. And I just listed my references here. This last reference on the hemodynamic monitoring is out of date, and I know I wasn't supposed to use that, so I did want to put it on there just because I feel that it was such a good article breaking down hemodynamics and how to monitor the patient and why it's done. It was really easy to understand, so I would suggest everybody go look at that one. And thank you very much.